Honorable committee members, thank you for the privilege of appearing before you. The last several months have offered us as a country extraordinary challenges. As an epidemiologist, internist, and parent, these challenges have subsumed every part of my work life and my personal life. I haven't hugged my kids since mid-March. I have watched patients admitted to hospital with mild breathing difficulties and seen these same patients wheeled into the intensive care unit 72 hours later. My colleagues have cared for married couples and have had to tell the surviving spouse of the death of their partner while on clinical rounds. I've had the gratifying experience of watching our modeling work influence policy, and I've also experienced the annoyance of watching epidemiological data abused, misused, and distorted in support of various political, economic, and social agendas. The challenges I have faced pale next to those faced by many Canadians who have lost their jobs or lost their loved ones, often without the chance to hold hands or say goodbye. They pale next to the challenges faced by those who have worked at essential jobs under pressure from employers, but without access to adequate personal protective equipment. We've watched extraordinary leadership from senior public health officials across the country, and here I'd like to single out the clear, compassionate messaging from Drs. Henry, Henshaw, and Tam for special praise. We've also struggled with more limited leadership in other provinces, and here I would note in particular the failure of provincial public health officials in Ontario to act swiftly and courageously to stop the spread of COVID-19 in long-term care facilities, failure to clearly articulate that COVID-19 was spreading in our communities in early March, and failure to keep up with the best epidemiologic evidence on important issues like transmission of disease by individuals with few or no symptoms. So yes, we have seen many challenges, some of which we have met and some of which we have not. My group prepares forecasts for several federal and provincial colleagues each morning, and we have documented a reproduction number for the epidemic in Canada below 1 since around May the 9th, 2020. That's a hopeful sign. The reproduction number of an epidemic, the number of new cases created by an old case, is an index of epidemic growth and decline, and a sustained reproduction number below 1 suggests that this first wave of the COVID-19 pandemic is approaching an end in Canada. I have been concerned at how this encouraging turn of events has been interpreted by some to mean that this wave is ending in spite of, rather than because of, the patient selfless actions of many Canadians who've experienced hardship, isolation, and deprivation in order to distance themselves from workplaces, friends, and family. In Canada, we have seen healthcare systems stretched and challenged, but we have not witnessed the tragic overflow of intensive care units as occurred in Wuhan, in Lombardy, in New York, and Madrid. Make no mistake, our failure to experience these tragedies does not mean that models were wrong. Cities around the world that failed to react to approaching epidemics as promptly as Canadian cities did have experienced astounding surges in mortality. A 300% increase in death in New York, 75% in Stockholm, 460% in Bergamo, 100% increase in mortality in London. We reacted to approaching disaster in time to avert the worst of this first wave, though in our two largest cities, Montreal and Toronto, we still have several hundred individuals in intensive care units. And now we face what I'll refer to as the paradox of prevention. By preventing widespread infection in the country, we've maintained susceptibility in the population, which leaves us vulnerable to future waves, future epidemic waves. This is the defining paradox of public health. Our fundamental deliverable is the non-occurrence of events. To those of us who work in the field, we're accustomed to having our outputs taken for granted. To note one familiar example, vaccination programs are criticized because their very success means we don't experience outbreaks. Perhaps a silver lining to this episode moving forward will be a greater appreciation of what public health provides us in normal times. But back to our successful avoidance of even greater tragedy in Canada in March and April. Having achieved this important success, we need to move forward with economic revitalization. And I think presentation of our choices as economic revitalization versus prevention of disease transmission is a Hobson's choice or a false dichotomy. We can't ignore our economy, but we won't have robust revitalization without strong surveillance systems and health protection measures. A frightened and grieving population will not drive a strong economy. In the United States, data assembled by JP Morgan Chase show clearly that declines in spending are strongly linked to levels of disease activity. The bedrock on which revitalization rests will be public health surveillance and laboratory testing. We can't see this epidemic without testing, and we can't fight an epidemic that we cannot see. The virus is a slippery foe, and it's a study in contradictions. I call it Schrodinger's coronavirus. It's dangerous and it's lethal, but it causes mild illness and even infection without symptoms. It kills over 7% of the Canadians with recognized infection, but it gives most children a free pass. Asymptomatic and pre-symptomatic infections are a Trojan horse, which gives entry to congregate settings like long-term care and retirement homes, healthcare facilities, prisons, and food processing plants. Once it's spreading in these institutions, it can take a terrible toll, as we have seen in long-term care facilities. We can look around the world for successful responses to this epidemic and emulate best practices, but we can also emulate best practices here in our own country. Colleagues in Newfoundland have controlled COVID-19 rapidly. They tell us to hunt the virus and be proactive. Colleagues in British Columbia teach us how important clear strategy and communication are in this fight. Alberta can show us how to scale up testing, and our northern territories show us how to protect isolated remote communities. Saskatchewan has shown us how to deal swiftly with growing outbreaks to prevent geographic spread of infection. But I do believe that our most potent weapon in the fight is testing. Work by my colleague, Dr. Ashley Chute, shows that without aggressive testing, control measures like contact tracing are likely to be fruitless, as we will only perform contact tracing on tested cases. If we fail to test at scale, we will miss too many additional cases for contact tracing to change the dynamics of the epidemic. It'll simply be a waste of resources. If we test at scale, we can keep the epidemic in our sight and move towards economic revitalization while keeping Canadians safe. Testing will be our eyes and ears as we move forward to open our economy, but the laboratory is a tool that needs to be used differently in different settings. We need to establish regular testing regimens for those who work in congregate settings with vulnerable individuals, especially in long-term care and in hospitals. Testing in a stable and consistent way allows us to estimate the reproduction number of the epidemic and know when we're headed back into exponential growth. We want to find all the cases we can. That's how we prevent sparks from turning into forest fires. Hospitalizations and deaths are easy to see, but they're lagging indicators. Instituting control policies once they are surging means we've already missed the boat. We can use non-traditional surveillance tools too, like web-based syndromic surveillance and even surveillance of sewage for coronavirus levels, as is already being done in other countries. Situational awareness will keep us safe as our economy comes back to life. We can also demand more of our country. This epidemic shows us that having laboratories with 21st century diagnostic technology, but public health information systems that depend on fax machines from 1995 will hold us back. We can demand more transparency from our leaders. As action by the public is central to disease control, it's important that the public be kept in the loop and made to feel like they're on the team. Indeed, they are the team. We need clear, transparent benchmarks across the country on testing, on turnaround times for case reporting and contact tracing, and for the reproduction numbers that will be used to determine when we need to strengthen distancing and when we can loosen it. We will have more setbacks. The countries with the strongest response programs in the world have all suffered them. We will too. I'd ask you not to throw up your hands and let the virus win. Don't let uncertainty distract you from the mission. Uncertainty is to be expected for a disease that's been in humans for 24 weeks. Don't let smug professors bully you about the absence of randomized controlled trial evidence for control of a disease that's only existed for half a year. We can acknowledge uncertainty and be humble about this disease, but always put the lives and livelihoods of Canadians at the forefront when we make our decisions. Thank you for the opportunity to answer your questions today.
Thank you for that direct question or answer. I appreciate that. Yesterday, Dr. Niemer talked about the task forces which she set up to tackle the Canadian pandemic response. She mentioned that although she could share the agendas, she couldn't share the deliberations or findings because they're secret. And I believe there are other countries around the world who have set up similar task forces that are sharing their research papers publicly, which help us all. Do you think that the findings of these task forces should also be public so we can have that timely data sharing for a better pandemic response?
I can't even believe that's a question. Of course, it has to be public. Science is conducted in public, always. And if you look at a country like Switzerland, they too have a task force on COVID, a scientific task force. If you go to the website, there are over 24 public reports by that task force published. If Switzerland, little Switzerland, can get 24 reports out of their task force by now, why does Canada have 0? It's shameful.
Thank you, Ms. Jensen. We go now to Mr. Fisher. Mr. Fisher, please go ahead. You have 6 minutes. Mr. Fisher, you're muted.
There we go. Thank you, Mr. Chair. Dr. Fisman, you have a wealth of experience in the battle against infectious diseases. Yet you've publicly explained that predictions that you made earlier this year on the virus were wrong. I think we can both agree that hindsight is 20/20, and there's been a lot of discussion at this committee about why certain decisions were made in the early days of this virus. I wonder if you could explain to this committee and to Canadians about the difficulties of making predictions around a novel virus and why what's considered the best advice one day can change and evolve so quickly the next.
I think part of the difficulty relates to the fact that viruses are the troublemakers, and I think Dr. Khan alluded to this. The troublemakers tend to be RNA viruses. That's the genetic material that come from animals, and RNA viruses are very good at mutating. And what we see with this virus, which is a cousin of SARS-1 and bears a lot of genetic similarity to SARS-1, is that it behaves differently in important ways. So being 80% similar can still translate into some very important differences, but some very important similarities. What we tend to see, what we almost always see with infectious diseases as they emerge, is we find out about hotspots first. So typically what we have is this sense of the virus being more virulent than it ultimately turns out to be. That's certainly been the case with some outbreaks. What we saw with this virus also initially was it looked a lot like SARS based on the information we knew from China. I know I've acknowledged this publicly that I think my biggest mistake was thinking it really was looking like SARS in China. We did some forecasting on how the Chinese seemed to be doing in terms of controlling it, and we accurately forecast that it would be done in Wuhan by early March, and that was right. The difficulty was that we didn't see Iran coming. And once you saw this in Iran, you sort of knew the game was over, and you knew that this was going to disseminate around the world.
Pardon me, Dr. Fisman, could you hold your mic up, please?
Oh, I apologize. I'm new to this. So you know, they're all the same, but they're all different. And when you look at some of the key parameters as we talk about them with these diseases that let you sort of predict how things are going to play out, some important numbers are the reproduction number of the disease, the number of new cases per old case. This virus turns out to be a real trickster in that it's got what's called an over-distributed reproduction number, where many cases are dead ends, but some individual cases make 40 secondary cases. And you see that play out again and again, whether it's in nursing homes, on cruise ships, in restaurants. There's a single individual in Korea who infected 40 secondary cases and sparked a massive outbreak in the city of Daegu. So that makes it difficult. It also provides, perhaps we'll talk about this, it also provides a potential vulnerability for the virus in terms of control, because once you get rid of those large gatherings that make super spreading events difficult, the virus becomes much less transmissible. The initial case fatality that we saw coming out of China, that's deaths per case, was listed as 2.4%. Of course, deaths go up slowly with this thing because people die in the ICU. So the China case fatality, I think at this point is 5-6%. We're at 7% in Canada. What we know now, and we've been helped a lot in this regard by data from Spain from last week, from a national seroprevalence study, where they're able to find both the recognized and the unrecognized infections, is about 5% of the country of Spain has had this, with 27,000 deaths. So now we're able to go from a case fatality in Spain, which is deaths per recognized case, down to an infection fatality rate, which from Spain we now are pretty sure is about 1.2% based on